Good evening, ladies and gentlemen, and welcome to this evening's webinar entitled Implantation Failure. Can this be caused by abnormalities in the immune system? I'm Dr. Juliet Skinner, and I'm the Medical Director of Barbados Fertility Centre. So this evening, what we're focusing on is the process which has to occur to take an embryo, which is a ball of cells, which lands within a uterine lining, either through a journey down the tube in natural conception or via an embryo transfer catheter in IVF conception, and transforms that embryo placed on an endometrial lining into a developing fetus, which has its own blood supply and attachment to the maternal circulation. So what are the critical factors affecting successful implantation? These would be continued embryo development, so in other words, capability. The fact that the uterine environment must be normal and healthy and ready for implantation. And lastly, but very importantly, the acceptance of the fetal allograft. To emphasize, this evening's webinar is on implantation problems not due to an error in embryo capability or uterine decidualization or structure. In other words, what we're focusing on tonight is errors in the fetal-maternal unit development. So, for many decades, we've understood and tried to study the endometrium and embryo interface, that junction between that ball of cells and that surface, and what has to go on to create that unity. And we know that the three basic early steps have been identified as apposition, adhesion, and invasion. What develops at the end of this is quite astounding. A fetal-maternal unit, or placenta as it's known, is this incredible structure which is a double vascular tree, and imagine that it is a whole plethora of arteries and tiny blood vessels and microscopic blood vessels that together create one unit, as well as the cells that surround this. The functions of the placenta are highly important. That the placenta is a means of which an embryo will receive its nutrients. It's a means of which the waste of the embryo will be removed. And it is functional. A placenta produces hormones and all sorts of other chemical agents. And it produces the liquor, which supports and protects the embryo itself in the amniotic bag. So in essence, successful development is crucial for sustained development of the embryo. And insufficiency of the fetal-maternal unit is associated with intrauterine growth restriction, which is effectively when a baby perhaps is born at term that was destined to be, for example, an 8-pound baby, but instead is perhaps only 4 or 5 pounds. An extension of this would include where, in fact, the nutrient supply is so severely reduced that it results in intrauterine death, or indeed miscarriage. Many years of research have focused on factors that affect the vascular development of the utero or placental tree. Indeed, antibodies, such as antiphospholipid antibodies, have been identified that can attach to placental cells and affect the development of these. Antibodies, for example, have been linked with this adverse reproductive outcome, such as IUGR, oligohydramnios, preterm labor and delivery, and miscarriage. Another group that's been highly studied includes thrombophilias, and these are conditions which predispose a person to clotting, and this can affect the successful fetal-maternal circulation development simply because blood clots that form in these tiny little blood vessels stop and limit their continued development and better interface. Thrombophilias may be inherited or acquired, and likewise are linked to adverse obstetric outcome beyond maternal thrombotic events, which are what we always assume the thrombophilias are linked with. So to zero in slightly more, let us try to think about the embryo-uterine interface beyond, or between, shall we say, the blood vessel connection. And if we look between these two layers, we see that there's a whole host of other cells and chemicals and, if you like, interaction that's occurring. Natural killer cells, T cells, monocytes, and a whole host of chemical reactions that are incredibly important to the successful implantation of an embryo. To take a step back, let's do a little bit of a basic refresher on the immune system. So our immune system is based on a whole plethora, if you like, of cells. And these cells circulate the blood system and effectively then transfer out of our blood vessels into our tissues. And these are concentrated around our boundaries. So our mucosal layers that line the gut and skin, for example, anything of where we could be invaded by an enemy. In terms of classification, we can divide these into lymphoid or myeloid, and of the lymphocytes, these are B cells, T cells, or natural killer cells. Our immune response is based on the essential understanding that our immune cells recognize any tissue or membrane as being either self or non-self. In other words, friend or foe. When a cell exhibits non-self markers, this will result in the immune system responding to destroy that enemy. And for example, when this is a bacteria or a virus, that is what we want our immune system to do. If we think for a moment of what pregnancy requires, it requires the immune system to break the rules, because trophoblast will exhibit non-self markers because it's half paternal. The arrangement on how these cells work together has been divided in classification into innate immunity and adaptive immunity. For reproduction, we're particularly going to be talking about adaptive immunity and the role of B cells, which produce antibodies, T cells, which produce things like tumor necrosis factor and interferons, and natural killer cells, which produce things like cytokines. And ultimately, all of these cells have the central goal, which is to destroy a cell that is not self. In schematics, I think this gives you a better idea of how cells exhibit their actions. So a natural killer cell has been shown to have 4 basic stages of going about its business. The first step is to recognize the target cell and rearrange its actin cytoskeleton. The second is to polarize the microtubule organization center and secretory lysosomes to the lytic synapse. The third is to dock, and if you like, fix on that cell. And the last, for want of a better word, is to shoot. To fuse and release the cytotoxic contents of your natural killer cell, which immediately will destroy the cell that it's just docked to. So where do natural killer cells come from? Well, they're made in the bone marrow. They are widely distributed within our body. They are very concentrated in the uterus. And we understand that there are different subtypes of these cells. So that a natural killer cell is a CD56 positive cell, and that's basically just the numbers and then the letters that we use for a certain surface marker. That some of these natural killer cells that, for example, do not have CD16 surface protein will produce interferon, tumor necrosis factor, and some that then exhibit CD16 are then more cytotoxic. The majority of natural killer cells identified in the uterus are what's called CD56 bright killer cells. A little bit more about what do we understand and know about natural killer cells in the uterus. Well, interestingly, natural killer cells are recruited into the uterus. The uterine levels of killer cells change dramatically with the menstrual cycle. So in the early part of the menstrual cycle, what we call the proliferative phase, only about 10% of stromal cells are natural killer cells. This will naturally increase as we go past ovulation into luteal phase, with maybe 20% of stromal cells being natural killer cells. And very quickly, in a case of pregnancy, this has been shown to increase to well over 30%, up as high as 70%. And interestingly, their appearance and then subsequent disappearance very much correlate with the development of the placenta. So after the second wave of implantation of the placenta, the presence of natural killer cells reduces considerably, back down to more basal levels. Animal models suggest that natural killer cells play an important role in the spiral artery and trophoblast development. And the theory, therefore, is that while they are important for the development of pregnancy, that if excessive or dysfunctional, they can predispose to failure. So what do we know about the associations of natural killer cells and outcome? Well, what studies have shown us is that if you identify patients with high natural killer cells, these patients have a 4 times higher likelihood that they had a miscarriage with a normal karyotype embryo. In cases of unexplained infertility, the identification that killer cells are increased carries a much lower chance that that patient is simply going to fall pregnant. And conversely, lower levels of natural killer cells are associated with higher live birth rates. Similarly, if we look at the balances of our T cells, and you look at patients who have normal pregnancies, their production of the more Th2 and their balances of Th2 cells, which produce interleukin 4, 5, and 10, and have been shown to be important in the normal development of trophoblasts and cellular division processes. This is associated with a normal pregnancy outcome. Conversely, patients with IVF failures are more likely to be found to have a balance much more towards the Th1 production pathway, which would be a higher level of interleukin 2, TNF, or interferon. And I think that the best way to think of this is that while these cells are incredibly important for normal development, it is the balance of these cells that is crucial. Now, obviously the first question would be, okay, well, how can we identify patients that have an abnormal number of killer cells? And this has remained a challenge. So the diagnostic testing of natural killer cells is difficult. If you look at the tissue sample of what's going on in the uterus, which is obviously our key focus, these would be assessed by an immunohistochemistry technique. And the challenge is that endometrium, as a structure, is very complex, it's glandular, and the counts of natural killer cells that have been identified in endometrium are hugely variable in one area or the other. I've already shown you that they're also variable with the menstrual phase, meaning that whether that test was done on day 7 or day 21 would naturally be expected to show very different levels of natural killer cells. So turning to the bloodstream, we can then assess natural killer cells in the peripheral circulation. And these are assessed instead by a flow cytometry method and ultimately are expressed as a proportion of all lymphocytes. They use surface markers of activation to identify individual subtypes. But again, this is important. Not all labs have the capability to do this. And there are interlab variability. And certainly, it's fair to say that there are only a handful of labs in the world that truly have the diagnostic accuracy of natural killer cell testing. So in these laboratories, the sort of results that we're able now to get would be an absolute natural killer cell level, which would be the number of CD56 cells that are seen in the flow cytometry. They're also able to give us a functional assay, which is the NK cytotoxicity, where these killer cells are exposed and are measured in their killer activity against target cells, K562 cells, and this activity is measured in the form of a 50-to-1 target effector ratio, and obviously therefore expresses the toxicity and the functional toxicity of the killer cells in question. They also are able to give us a measurement of the Th1 to Th2 balance of cytokines, so that we're able to see the TNF to interleukin 10 ratio or interferon to interleukin 10 ratios. And in some laboratories, they have developed a cytotoxicity suppression test, which looks at how this functionality is changed with the addition of the two agents of which we actually use, such as IVIG or intralipid, to see how that functional toxicity can be reduced and modified. So what we would find or get as a result from these laboratories would be something that looks like this result, where for this patient I'm able to identify that she has an elevated number of CD56 cells at 14, that the functionality of these cells is extremely high with a 50-to-1 target effector ratio of 20, and anything above 16 is considered elevated. And when we look at the impact that potentially the two agents IVIG or intralipid would have on that functionality, we can see that this patient would respond better with intralipid, with a better reduction of the functional aspects of her natural killer cells. And this, therefore, as a clinician, becomes incredibly useful to guide me. What do I do next? And ultimately, this brings us, therefore, to the consideration of, the role of therapeutic agents in being able to immunomodulate that environment. So a number of agents have been considered, be it the anticoagulation with heparin, be it broad immunomodulators like prednisolone or dexamethasone or steroid agents, or the more specific IVIG or intralipid infusions, which are a drip medication given roughly monthly for the first 3 months of pregnancy, commencing prior to the embryos being transferred in IVF, or the more specific TNF alpha blockers. And ultimately, the key question is, can we use these drugs to alter natural killer cells and cytokines, and in altering these, will this change the reproductive outcome for that patient? What has been looked at is the role of this treatment in recurrent miscarriage, IVF failure, and unexplained infertility. So I'm going to show you some data now that has been published on studies asking this question. And this was one of the early studies back in 2002 in a recurrent miscarriage setting. So there were 83 patients who had had 3 or more miscarriages before, and they were tested as having abnormal immune testing. They were given the choice to take a new drug at that point, IVIG, for this indication, and some patients took it and some patients didn't. Of the 22 patients that refused to take the treatment, 87% of those, when they got pregnant, suffered a further miscarriage. Of those patients that opted to take IVIG, the results were almost the opposite. That indeed, nearly 90% of these patients did not have a miscarriage, but had an ongoing pregnancy and a term delivery. So this was extremely exciting news back in 2002. Studies have tried to evaluate the role of other potential therapeutic agents, be it heparin alone, heparin and IVIG, or indeed the question about would a TNF blocker assist further, and again produced encouraging results. So what about without miscarriages in a different clinical setting? This was a study that then looked at patients with unexplained infertility who were having IVF. And in this setting, the inclusion criteria were that those patients had to be younger patients under 38, and they had to have 5 or more 5-cell embryos to be considered suitable to be included in the study. They were tested according to their natural killer cells, and the patients opted to whether they took treatment or not, based on their previous failure of IVF or previous unexplained. For those patients that had normal levels of natural killer cells, given IVIG or not given IVIG did not make a difference to outcome. And that's important because that's what we would expect. And I think importantly, on the converse, given IVIG did not have a negative impact. Now, for those patients, however, that had abnormal levels, it's very important that when we look at those patients that opted not to have treatment, the outcome was indeed very poor. It wasn't that there was no chance of pregnancy, but it was considerably reduced over the group that agreed to be treated with IVIG and indeed have a successful outcome. Again, same group, basically exploring the clinical question of the role of IVIG, Humira or both. And again, importantly, the take-home message from this slide is abnormal results with no treatment had a poor outcome. It's a small study, so I think there's a limit to what we can take from this slide, but treatment with either IVIG, Humira or indeed both all conferred benefits. In summary, abnormal natural killer cells and Th1 cell production are associated with adverse reproductive outcome. Testing is possible, but it does have its technical challenges and it is costly. Treatments have been evaluated in small retrospective studies only, but they do show promising results. And I think it's important that yes, some of these treatments that I've talked about are costly. So IVIG and Humira are about $2,000 US per infusion for IVIG and per course for Humira. However, in targeted patients, the outcomes appear to be significantly improved. So this always, I guess, tests us clinicians. Should we test all patients? And I think the opinion is very much that if testing was done in an unselected population, well, the majority of people that we tested would be normal. The cost of the test is about $750 US, so it's not an inexpensive test. And it does beg the question that without a background of implantation failure or miscarriage, there will be some minor abnormalities that we would identify if we tested that maybe do not need to be treated. And therefore, the end result would be that if all patients were tested and any abnormality treated, we probably would overtreat. That same question posed differently. Should we test higher risk groups? Patient recurrent miscarriage, patient recurrent IVF failure. And yes, this gets into the grey question of, well, how many IVF failures and how many embryos and what quality of embryos would constitute recurrent IVF failure? Unexplained infertility, how long? Were there any other factors? And I think that these certainly are all questions that make us think, should we think about testing further? So the clinical experience at BFC is that we have at this point treated numerous patients with multiple previous IVF failures prior to seeking care with us, where based on those failures we have tested and if abnormal treated, and that our IVF care has resulted in a successful outcome. And I don't for one second believe that we were the only IVF clinic that produced capable embryos. It has to be that we were the clinic that treated the whole picture and ultimately treated the most important key to success. I think with respect to the exact treatments, these are guided by the results of the antibody screening, the natural killer cell assessment, cytokine analysis, together with past obstetric and IVF treatment history. And in crucially important, as with all IVF care, that care must be individualized. As a clinician, the triggers that prompt me to think about immune evaluation would be past IVF failure with good embryos, recurrent miscarriage, a long history of unexplained infertility, particularly at a young age, and perhaps a medical history of other autoimmune conditions which increase the probability of other coexistent immune abnormalities. At Barbados Fertility Centre, we have always believed strongly that a 1% improvement in success rates is a baby for someone. I think in the case of immune treatments for immune implantation failure, this is one of those examples where thinking about it, identifying it and treating it has a phenomenal impact to successful outcome. I thank you for your attention, and I hope in the course of this last half an hour that I have made what's a reasonably complicated area seem somewhat more understandable. Thank you.